Welcome to our parent education workshops for parents of children with congenital heart disease. Today, Dr. Kim Myers and myself, Dr. Marsha Vasserman, will be talking about the heart and brain connection in kids with CHD.
I'm Kimberly Myers. I'm a pediatric cardiologist at Alberta Children's Hospital in Calgary, Alberta. So, why are we talking about brains in kids with congenital heart disease? The story of congenital heart surgery in Alberta started in the mid-1950s with this man, John Callahan, pictured here. He was one of the great pioneers in cardiac surgery worldwide. He joined the Department of Surgery at the University of Alberta in 1955. He performed Canada's first successful open heart surgery in September 1956 on a patient with an atrial septal defect, or a hole in the top chambers of the heart. This is followed in 1957 with the very first tetralogy of Fallot repair in a patient named Dolly Ann. Ironically, his great-granddaughter would undergo her own repair of tetralogy of Fallot almost 60 years later. Her surgery took under 2 hours compared with the epic 10-hour procedure that her great-grandfather performed. Cardiopulmonary bypass, or the heart-lung machine, did not exist in those early days. Instead, surgeons used a procedure called cross-circulation for open heart surgery. In this scenario, the child, which is here on the right, is connected to his parent's circulation here on the left. The blood is oxygenated by the parent's heart, and then the blood is returned to the child. This technique was ultimately abandoned because it put 2 patients at risk instead of 1. Along the way, surgery for congenital heart disease was in its infancy in those early years between the 1950s and 1980s. Prior to the 1980s, it was very uncommon for a child with complex congenital heart disease to survive even beyond the first year of life. This is data from Norway showing their survival rates between 1971 and 2011, and these rates were very similar in other centers worldwide. Now, this graph shows lines in red and purple, and those were patients operated on in the 1970s and 1980s. The lines in green show survival in patients operated in the early 2000s. These curves show survival here on the y-axis with 100% survival at the top and 0% survival at the bottom, and age in years on the x-axis. And what it shows is very dramatic improvements in survival for patients with single ventricle disease here, truncus arteriosus here, interrupted aortic arch, and pulmonary atresia in particular. There were 4 key technological breakthroughs that changed the landscape for caring for children with congenital heart disease. Cardiopulmonary bypass, or the heart-lung machine, allows blood to be redirected away from the heart to a machine that filters, oxygenates, and heats the blood before returning it back to the patient. This allows the surgeon a bloodless field. It is operated by a perfusionist who sits here behind the surgical table. The development of the IV medication called prostaglandin to keep the ductus arteriosus open, or what we also call the duct, to allow enough flow to the lungs in a blue baby, was game-changing, as was the ability to perform cardiac surgery in neonates, which are babies in the first month of life. Finally, the development of cardiac catheterization allowed early diagnosis of congenital heart disease long before we had cardiac ultrasound or echo. We still use cardiac catheterization for diagnosis of heart problems, but also to treat some heart diseases. Down here on the right, you can see some of the devices that we use in cardiac catheterization, including various balloons, stents, and even valves that we can implant. And we are able to dilate or stretch blood vessels and keep them open here with stents to allow blood to go where we need it to go. We can close holes or blood vessels to stop blood from where we don't want it to go. And we can even implant valves without needing surgery. This graph on the left shows the impact these developments have had on survival in patients with congenital heart disease. Over this 50-year period in the United Kingdom, you can see the decline in deaths of babies under 1 year of age, shown here in blue, with improvement in survival, shown here in yellow, with the advent of cardiopulmonary bypass, the introduction of the Fontan surgery, the introduction of prostaglandin, the arterial switch procedure for transposition of the great arteries, and finally the Norwick procedure for hypoplastic left heart syndrome. In this graph on the right, this shows great to excellent long-term survival for many congenital heart disease patients, including those with mild disease like atrial septal defects or ventricular septal defects, with more than 95% survival at after 25 years of age. Those with moderate congenital heart disease like AVSD or transposition of the great arteries, with 89% surviving beyond 25 years of age. Severe two-ventricle disease with 72% survival, and those with single ventricle disease with more than 44% survival. With such remarkable achievements in survival for these children, we've actually seen a shift so that in 2010, we started to see the number of adults living with congenital heart disease exceeding the number of children living with congenital heart disease, certainly in the United States and Canada. And we are just starting to appreciate the neurodevelopmental challenges that adults with congenital heart disease have faced. And we're now witnessing the problems that our kids with congenital heart disease are struggling with. Children with congenital heart disease have been shown over and over to have a specific pattern of neurodevelopmental challenges. We will learn more about these issues in the next sessions of this series. But in brief, about 1/2 of children with congenital heart disease have neurodevelopmental disability, most mild, but still very impactful on their lives. We know that our kids generally have normal IQs, but often in the lower range of normal. Many struggle with speech and language. They're frequently impulsive and hyperactive. There are higher rates of autism and inability to make or keep relationships. Many have anxiety or depression throughout their life. These challenges impact the quality of life for many adults with congenital heart disease. This is data from a Dutch registry showing that both men and women with severe congenital heart disease fail to finish secondary school. Many struggle with unemployment and low income, and a large number of men with single ventricle disease remain single throughout their lives. Many adult patients suffer from poor self-esteem, and there are very high rates of anxiety and depression amongst these patients. So let's look at some of the possible causes to changes in the brain with children with congenital heart disease. By about 9 weeks gestation, shown here in the top right, the brain is a small, smooth structure, but the basics of the nervous system are already established. Over the next months, the brain structures grow and the outer parts of the brain begin to fold into distinct brain regions. Neurons in these special regions begin to make chemicals that will allow them to connect to other nerve cells. The fiber pathways that become the brain's information superhighway within white matter start to form. The third trimester, between 6 and 9 months of gestation, is where much of the growth and infolding of the brain occur. Even after birth, there is ongoing brain development. By 6 years of age, the brain has reached 90% of its adult volume. And by age 25, we consider the brain fully developed. Many types of congenital heart disease produce abnormalities in blood flow in the fetus. First, a reminder of how blood normally flows through a fetal heart. Remember that the right side of the heart, the right atrium and the right ventricle, pump deoxygenated blue blood to the lungs. And that pink blood that returns from the lungs to the left side of the heart, left atrium and left ventricle, are then pumped through the aorta to deliver that pink oxygenated blood to the brain and then around the corner to the abdominal organs. As a fetus, babies are not breathing, and pink blood is returning from mom's placenta to the right atrium, and there is a natural communication or hole between the top chambers of the heart that allow that pink blood to stream to the left side of the heart and there to the aorta and the developing brain. Blue blood returns to the right side of the heart, passes through the ductus arteriosus or duct to the abdominal organs. Now, this cartoon shows transposition of the great arteries, where the two big blood vessels or arteries leaving the heart have swapped positions. In this way, the aorta arises from the right side of the heart here, and the pulmonary arteries from the left side of the heart. Pink blood returning from mom's placenta to the right atrium still passes through that natural connection to the left atrium, but instead goes through the ductus arteriosus to the abdominal organs. Blue blood returning to the right side of the heart now passes through the aorta to the brain. And so in babies with transposition of the great arteries, their brains are receiving actually blood that's lower in nutrients and oxygen than they need at a time when they are most vulnerable. This is a cartoon of hypoplastic left heart syndrome, where the chamber on the left side of the heart is very underdeveloped, often due to problems with the mitral and the aortic valve. The pink blood coming from the placenta can no longer pass through that atrial communication to the left ventricle, and instead enters the right ventricle along with the blue blood returning to the right side of the heart. This blood is now of mixed oxygen level, and that lower oxygen blood passes through the ductus arteriosus, not just to the abdominal organs, but it also passes backwards through the very small aorta to deliver less blood flow than needed of lower oxygen and nutrient concentration to the developing brain. We are learning more and more about the genetics of heart diseases. We see congenital heart disease in many genetic syndromes, including trisomies like Down syndrome, trisomy 13 and 18, as well as microdeletion syndrome like DeGeorge syndrome and Williams syndrome, and single gene defects like Kabuki syndrome and Noonan syndrome. And all of these genetic syndromes have a specific pattern of congenital heart disease that we anticipate. We are learning that these genetic changes cause many of the differences in the organs of these kids, including the way the heart forms, but also the way their brains develop. Some of these kids will have developmental delays or behavioral problems, and we are understanding that these are linked to their genetic changes. After birth, there are other concerns that impact the way the brain functions and develops. We know that babies born prematurely are at higher risk as their brains are already immature. After birth, when babies start to breathe air and use their lungs, the blood flow patterns change dramatically. Where there is little flow to the lungs in the womb, now all of the flow must pass through the lungs to get enough oxygen for organs to function. These changes in blood flow sometimes result in lower blood pressure or lower oxygen levels, both of which add risk for additional injury to the baby's brain. Some babies lose the heart's ability to pump blood flow adequately and need CPR or ECMO for a short period of time, either before or after surgery. These both have the potential to injure the brain with risk of stroke. Some of the procedures that we do to babies with congenital heart disease, like opening a hole in the top chambers of the heart with a balloon or ballooning a valve in the first weeks of life, can also cause injury to their brain. About 40% of infants with congenital heart disease who need heart surgery in the first month of life have brain injuries that we can see on CT or MRI even before surgery, meaning they were born with that injury. Another 1/3 will develop a new injury after surgery. The most common injuries to the brain are damage to the white matter, followed by strokes and bleeds. These images show injury to the brain in over here, a child with hypoplastic left heart syndrome. Seen here is this bright spot, and this other child with hypoplastic left heart syndrome, again showing these changes here, and this baby with transposition of the great arteries here. And all of these injuries occurred during surgery. For many years, we tried very hard to understand how we could protect the brain during surgery to prevent injuries like these. We changed cardiopulmonary bypass technique, but we know that they cause only a small fraction of the injuries to the brains of these babies. The intensive care unit is another place that may contribute to brain injury. As many of you remember, the ICU environment is filled with bright lights, loud noises, cool temperatures, frequent handling of babies, and frequent painful stimuli. Many babies have postoperative seizures or may need ECMO for part of their ICU stay. Some have bleeding or clotting problems. Some have heart rhythm problems. We know that babies that need long stays in the ICU have a higher risk of neurodevelopmental issues later in life, regardless of the surgery that they had. Overall, though, what happens during surgery and after surgery only explain a small portion of the brain injuries that occur, less than 5% of neurodevelopmental problems, whereas genetic changes and cardiac disease, along with abnormal blood flow in the fetus, account for up to 25%. Childhood and adolescence are also times of vulnerability. Some kids require additional heart surgeries or cardiac catheterization procedures. For children with heart conditions that will need a Fontan procedure, we keep them quite blue for the first years of their life, likely contributing to neurological injury over time. These multiple procedures and the scars that they leave on the outside can profoundly impact self-esteem and the feeling of being different from their peers. Many heart conditions impact exercise tolerance and the ability to keep up with peers in sport. Neurodevelopmental changes may limit the ability of some adolescents to pursue higher education. Finally, transition from pediatric to adult care happens at 18 years of age in Alberta, at a time when there are many changes going on in a young person's life. Young adults with impaired ability to plan, to make decisions, problems with memory and attention, contribute up to 50% of kids with congenital heart disease that fail to make the jump to adult care and are lost to follow-up. We are seeing higher rates of dementia in our adults with CHD, sometimes under 65 years of age. We're looking at why this is, and we wonder if their brains are more vulnerable because of all the injuries that they've accumulated throughout their lifetime. We need to understand this more in coming years and find ways to improve their outcomes. So, what have we learned? We've learned that our kids' brains are different. Those differences start when they're in the second or third trimester of pregnancy. Some of those changes are genetic, even if we don't know for sure what the genes are that are causing the changes. Some of those changes are due to differences in the way the blood gets to the developing brain, resulting in less oxygen and nutrients, smaller brains with immature folding, and often injuries in the form of tiny bleeds. We have learned that the therapies we do to kids with serious heart disease, like surgery and catheterization, anesthesia, CPR and ECMO, all add additional insults to vulnerable brains. We know that kids with serious heart disease have a specific pattern of developmental problems. And while most of these are mild, they greatly impact all aspects of that child's life, and for some adults, result in challenges in taking their rightful place in our communities. And with that, I will hand over to my amazing colleague, Dr. Vasserman, but not before reminding you that internationally, Congenital Heart Disease Awareness Week occurs February 7 to 14 annually. This slide indicates Congenital Heart Defect Awareness Week. There's sometimes some confusion about disease versus defect, and typically we don't think of the heart as having defects so much as a pattern of various changes in the heart that comprise congenital heart disease, and mostly just semantics. But with that, I pass over to Dr. Vasserman. Thank you.
As you heard Dr. Kim Myers talk a good amount about the heart and some of the connection it has to the brain, I'm going to be focusing more on how the brain develops in kids with heart disease, both before birth and after birth, and some of the functional impact that some of those differences might have. As Dr. Myers mentioned, the brain and heart develop in parallel. There's lots of genetic and environmental influences that can impact heart development, which also will impact brain development. And additionally, as Dr. Myers had mentioned, there's lots of changes in the cerebral blood flow and oxygenation delivery in kids with congenital heart disease. One of the things to remember is that even though a lot of the nutrition and blood demand and supply that babies have in utero comes through the mother and through the umbilical cord and placenta, as babies develop, that really changes and the heart starts to take on a much bigger role. So by the third trimester, brain metabolism, growth, and organization become very dependent upon adequate oxygen and nutrient delivery from the heart. And that's where some of those changes can really start to happen. One of the things that we see in the brains of babies with congenital heart disease is a wide range of differences, both chemically as well as structurally, that can affect function. So, for example, there's lower cerebral and acetyl aspartate choline ratios, which are a marker of brain maturation. There's elevated brain lactate in the fetal brains of kids with heart disease. There's also delays in the folding patterns of the brains of babies with congenital heart disease. And overall, one of the things that kind of tells us is that the brains of babies with congenital heart disease tend to be less mature than those of babies without heart disease. They're also very similar to the brains of babies who are born premature. And this puts them at greater risk. This dysmaturity and immaturity of brain development puts them at greater risk for other brain injury. And one of the biggest areas that we see problems in is high rates of white matter injury that I'll talk a little bit more about in greater detail. So how common is brain injury in babies with congenital heart disease? One of the things that we see is that up to about half of newborns with congenital heart disease are classified as neurologically abnormal. Now, this can mean a wide range of things. It could mean that they're slower to suck, they have a less developed suck reflex. It could mean that they might have some asymmetry in their strength and their limb movement. It might mean that they're low tone, aren't moving as much. It could mean they have a weak cry. So that classification is not very specific, but generally up to half of the babies with congenital heart disease will have some sort of neurological abnormality at birth. And even babies who don't demonstrate that visible distress or lack of oxygen might have white matter injury. So over 20% of infants will have what's called periventricular leukomalacia, which really means there's changes in the white matter, but they might not demonstrate any overt symptoms of that. And while there aren't many studies on this, the ones that have been completed using EEG recordings, so looking at the electrical activity of the brain, have shown that almost half of babies with congenital heart disease have an abnormal EEG. This just means they're not having seizures necessarily, but they're having some abnormalities in that electrical brain activity. But 42% of them will have some sort of epileptiform activity that might look like seizures. And 3/4 demonstrate what's kind of called as disturbed background activity. So just kind of the background of their EEG, of their brain electrical activity, is not quite typical. And these EEG recordings seem to have good sensitivity. So they definitely show that something's not quite right, but they are not very specific. They don't tell us why or what's driving some of those abnormalities. However, one of the things that has kind of come out of some of that literature is that postoperatively, when kids with congenital heart disease undergo surgery, if they have abnormalities on their EEG in those first few days after their surgeries, that tends to be a pretty good predictor of neurodevelopmental outcomes, even if there aren't any overt seizures. So that postoperative period is quite important. And when we look at cranial ultrasounds and MRIs of babies with congenital heart disease, anywhere from a quarter to more than half, 28 to 59%, have some sort of degree of brain injury before their cardiac surgeries. So we do see that a lot of these injuries pre-exist or predate the surgical interventions that these kids undergo. So what's white matter? When we look at the brain kind of in a gross type of way, it looks white on appearance. That's why it's called white matter. And then there's kind of grayish parts of the brain that's called gray matter. And the gray matter consists of all the cell bodies. So all of those neurons and brain cells, they have a cell body, and that's kind of the gray part. And then the white matter is really the sheaths and the axons. So those very long tails of the neurons that deliver messages from one cell to another. Well, what does white matter do? We know that there's high rates of white matter injury, but what are some of the functional impacts that can potentially result from those? So the purpose of white matter is, if you think about wires, in electrical wires, they're generally these little metal wires within some sort of sheath. And so white matter is that same sheath within our brain. It makes messages travel more quickly. It allows for cells to communicate very quickly and for messages to travel from one part of the brain to another in a faster way. And this supports all aspects of cognition. We know it's implicated in motor skills, in visual spatial understanding and perception, in speed of how quickly we can process information and produce some sort of output, very much implicated in attention, our ability to kind of sustain focus, resist distractions, as well as executive functioning. And those are the skills that include planning, organizing, thinking ahead, juggling many pieces of information, as well as resisting impulses and inhibiting our responses. So when we think about all of these potential impacts on the brains of babies with congenital heart disease, there's a bit of a kind of a cycle that happens. So we have these immature brains that are at greater risk for additional injury. Then there's potential for additional growth delays because of just lower oxygenation as a result of the heart disease. And there's impaired kind of generation and migration of neurons as well. So the neurons that are developing might not be traveling to the right spot. And there's also an overall reduction in brain growth. And all of these things put kids with congenital heart disease at higher risk for neurodevelopmental concerns. And that kind of brings me to this next slide, which is how do these brain differences translate into function? We know that babies and young children with congenital heart disease, with critical congenital heart disease, have higher rates of developmental delays in basic motor and basic language skills. They might be slower to walk. It takes them longer to start running. They might be less coordinated and have more difficulty with balance. They might be slower to talk, and to develop language, they might have more articulation problems when they're very young. As they get a little bit older and enter school, we see higher rates of learning difficulties as kids enter school. They might be more likely to have some attention problems and difficulties with those executive functioning skills. And oftentimes, unless a child is really hyper and impulsive, some of those might not become evident or visible until kids are a good amount older and reach that middle school age where they have to start planning and organizing both their academic work and their personal lives. And we start to see some of those difficulties pop up. They might have increased mood and anxiety symptoms. And they also tend to have higher rates of social difficulties and peer relationship problems, right? So they have a harder time making friends, keeping friends, might feel more lonely, and that also ties into some of the mood and anxiety difficulties that are often seen in kids with heart disease. So what are some things that are being done? We know that there's higher rates of brain differences. There's higher rates of functional impairment, neurodevelopmental struggles in children with heart disease. And because of that, one of the things that has happened is that multiple organizations, including the American Heart Association, American Academy of Pediatrics, have put together guidelines saying that we need to be following these children and trying to identify some of these difficulties early on so that we could intervene. So there's guidelines for surveillance and screening and assessment of kids with heart disease. And those guidelines state that surveillance really should occur for all kids with congenital heart disease, even those with low-risk heart defects, because that risk can change over time. And what surveillance includes is really your physicians just kind of checking in and asking questions about how things are going. And then screenings are recommended at specific ages, usually in the first couple of years at about, 6 months, 12 months, 18 months, and then at 2 for school age, right? And those screenings are a little bit more in depth and really try to get a better understanding of motor development, language development, academic development, intellectual development as kids get older. And if any of those are positive and kind of show us that there might be some areas of difficulties, then a formal assessment is recommended. or if a patient or if a kiddo is identified as having high risk, then formal developmental evaluations are necessary. Based on some of that information and those guidelines, we've developed some programs to really try to address this need and some of these gaps at Alberta Children's Hospital. We started a cardiac neurodevelopmental screening program. And what that is really just at every year at your regular cardiology follow-up, we provide parents with some standardized questionnaires that look at all of the areas we know tend to be more likely to have struggles in. So attention, executive functioning, learning, mood, anxiety, peer relationships. And if there's any concerns that are brought to us through those questionnaires by the parents, then we make referrals to whatever are the appropriate resources. We do have a neuropsychological assessment program at Alberta Children's Hospital. So if there are cognitive learning concerns or developmental concerns, then kids can be referred to a service that way. We've started these parent education workshops in part because a lot of families have told us that they don't feel that they've gotten enough information on how to support their kids through some of these neurodevelopmental problems. And we're hoping to bring some behavioral interventions for families of young kids with congenital heart disease who might have some behavioral difficulties. And we're constantly working on increasing collaborations between organizations and bringing folks together with the goal of further supporting families with kids with CHD. So what should you do if you have concerns about your child? I think the first thing is always to talk to the cardiology team and your cardiologist. Most cardiac programs have some sort of a relationship with either psychologists or a neurodevelopmental program within the community or within the hospital, and they might be able to refer you to community-based resources depending on what those concerns are. If you have developmental or learning concerns about your kiddo, contact your child's school. One of the things that we've learned through this process is that most schools do not understand the connection between the heart and the brain and learning and development. They do tend to have this perception that once congenital heart disease is treated or surgically repaired, then kids are fine and should be able to do as well and function as easily as other kids. And so I think some of that can be just addressed through conversations and giving them resources and educational materials around this. If your child doesn't have an individualized program plan, an IPP or IEP, then talking to the school about how to get one developed is a good starting point. And if the concerns are primarily learning related, then you can also request that your school conduct an assessment, although that's also sometimes difficult to do depending on their resources, but generally they do have some opportunity to provide assessments to kids who are struggling. And here are some specific resources that might be helpful. If you were in Calgary, Heartbeats is a wonderful organization that provides families with information, resources, financial assistance, and a wide range of both emotional and social supports. They have local parent groups as well as local children's support groups. And then the Western Canadian Children's Heart Network is also a great resource for anyone in Western Canada. They have resources by province, so you could look for more specific local resources as well as more general resources for kids and families with CHD. Thank you for joining us. If you want to learn more about neurodevelopment and mental health and congenital heart disease, please subscribe to our YouTube channel and follow us on Instagram. We are called Strong Hearts, Growing Minds. In the post section of the YouTube channel, you can also find handouts on various topics, while our Instagram account will keep you updated on new upcoming workshops.